Good evening, everyone, and welcome to another in our series of COVID-19 webinars put on by the Primary Health Network. My name's Scott White. I'm the Communications Manager with the Primary Health Network. And before we do get on with proceedings this evening, I would like to do an acknowledgement of country and certainly acknowledge all those elders, past and present, on all the lands across our Oh, got that bit thing this evening, didn't I? There you go. I've only done it, I don't know how many times, so I will start again. I would like to acknowledge the traditional custodians of the lands on which we're broadcasting this evening and pay my respects to elders past and present. And before we do get on to this evening, I'm going to introduce Allison Tattersall, who is our Education Manager. And Allison is going to give us a little bit of more information, specifically around COVID-19 and how it actually relates to the role of medical practice assisting. So over to you. Thanks, Allison.
Thanks, Scott. Good evening, everyone. My name is Allison Tattersall and I'm the Education, Workforce and Scholarship Team Leader at the Hunter New England Central Coast PHN. The PHN has been committed to the Medical Practice Assisting project for almost 2 years. We have 100 students currently working in general practice who are being assisted with a scholarship provided by the PHN of up to $2,500 per scholarship. This is also the result of a successful partnership with UNE Partnerships, and in particular Margaret Kirby, the Program Director, and Kate Charles. Tonight we have 182 people online, which is hugely exciting. I've been very passionate in getting this fairly new role in New South Wales into general practice. As some of you are aware, we had to postpone our conference, the first inaugural conference, and graduation at the onset of COVID-19. And I'm very pleased to let you know that we've set the date for next year for the 19th and 20th of May 2021. I'd also like to let you know that the next expression of interest will be released to our PHN tomorrow. There are limited places and I'd like to invite you to encourage as many people as possible to apply. I'd like to now hand over to Kathy Bainey. So I'll just tell you a little bit about Kathy, our presenter. So Kathy's here tonight for UNE Partnerships. Kathy is the Academic Director of the Health Program for UNE Partnerships and consults with practices nationally on governance and practice management issues. She is a registered nurse and certified practice manager and continues to manage a multidisciplinary general practice and a specialist practice, and has also held a position with New South Wales AMA as Practice Management Advisor. So thank you for coming tonight, Kathy.
Thank you.
I'll hand over to you.
Which way? Thanks very much, Alison, and to Scott and to the Hunter New England Central Coast PHN for facilitating this evening and for asking me to come along. Alison has asked that we have a look tonight at how the MPA role fits with the COVID-19 and the challenges that we're facing in our practices managing this pandemic. Skip a few there. Okay, so it was around about on March 11 that the World Health Organization declared COVID-19 a worldwide pandemic. And I think regardless of the role that you have in your practice as a frontline healthcare worker, we are being challenged as never before in our practices to manage this health emergency. In particular, our knowledge and practical skills of infection control. It's imperative at this particular time that we take all the care and precautions we can to protect ourselves, to protect our co-workers, to protect the families that we go home to, and most of all, to protect the patients in our care. So your qualification as an MPA means you are extremely well placed in your practice, not only for infection control measures, but many of the activities that are now emerging as our day-to-day workflows. The Chief Medical Advisor has repeatedly said that this is not a time for complacency and that they are expecting outbreaks. In fact, today he actually said it was the C word. Took me a sec, but he did mean complacency. And they are stressing that we don't become complacent with our practices and the way that we're operating our practices. So let's have a quick look at what we know about COVID-19 and how it will impact on your role in the practice. So both the challenges, but also the opportunities that may arise and be present for MPAs. Okay, so just a quick look at the incubation period. Those of you that have completed the unit will remember that an incubation period is the period between exposure to an infection and the time that those first symptoms appear. So the World Health Organization currently estimate that the incubation period for COVID-19 is 1 to 14 days, with a median incubation time of 5 to 6 days. What that means is that you could develop symptoms at any time during that 14-day period. Those symptoms are only transferable to others, generally in the 48 hours before your own symptoms appear, or the person that has COVID-19, when those symptoms appear. The symptoms range from extremely mild. They can be a sniffle to severe respiratory illness that requires intubation and sometimes leading to death. And one thing that's really making it difficult for us is that the symptoms are very wide. So we can have a fever, we can have a scratchy throat, joint aches, muscle pains, nausea, diarrhea, and it makes it really hard to distinguish COVID-19 from other less harmful viruses. We also know that the elderly, the immunocompromised, and those with chronic disease and comorbidities such as heart disease and diabetes are most at risk. We have instances of death across all age demographics though, and also we are seeing severe illness and death in otherwise healthy people. And we look to horror at the numbers in Europe, the UK and America. And I think most of us feel very grateful that we're living here in Australia and are managing this emergency as well as we are. So I'm going to have a look at infection control and the MPA role in infection control. Oh, sorry, Allison has asked me to remind you that you can ask questions tonight, in one ear and out the other, sorry Allison. You can ask questions tonight using slido.com. So if you download slido.com, that's an app, or you can go to the portal, slido.com, got it? And the code that you need to use is MPA, for Medical Practice Assistant. Okay, so any MPA who has been in a classroom with me will remember that every patient who comes into your practice is to be treated as a potential source of infection, and that every encounter with a patient is to be risk assessed. So both to the patient and to yourself, what are the risks? Those two fundamentals of your training as an MPA have never been more applicable than they are now. Currently, the only two strategies we have to manage this outbreak are social distancing and our infection control procedures. And it would seem that the failure of those infection control procedures are responsible for the degree of tragedy that we're seeing in that nursing home in Western Sydney. So I cannot impress upon you enough the importance of knowing your procedures and strictly adhering to them. All right, so how is this virus transferred? It's droplet. Okay, so you are going to come into contact with this virus with close proximity to another person that has it, who may be coughing or sneezing or breathing very heavily because they are short of breath and therefore they are breathing heavier than normal. So droplet, the same as influenza, and these droplets, just like the influenza virus, are too heavy to stay in the air. They fall to surfaces fairly quickly. Hence, we have that 1.5 metre distancing that we all know and have embraced. So the droplets fall to the surfaces fairly quickly. And just like influenza, these droplets, the virus, can live on hard surfaces like plastic or metal, like your keyboard, like your phone, like the reception counter and the door handle in your practice. Okay. So by touching a contaminated surface and then touching your eyes, nose or mouth before washing your hands, you could infect yourself or transfer the virus to another surface, which then may infect somebody. And according to the World Health Organization, it's not certain how long these coronaviruses live on surfaces, but they do think that just like SARS and MERS, COVID-19 can live for hours and potentially up to several days. It will depend very much on the surface that it falls on and the conditions of the room, the temperature and the humidity. We know that every one person that has coronavirus or COVID-19 will transfer it to at least 2 to 3 other people. Therefore, anyone with respiratory illness should not be at work while they are symptomatic. This includes mild respiratory symptoms and especially an unexplained fever. We can now perform testing, widespread testing, and we can get those results fairly quickly. In fact, someone I know actually had a swab done at 12:30, and by 5 minutes past 8 the next morning they had a negative test result on their mobile phone. That's how quick that these results are being pushed out. Okay, so to prevent the transfer of coronavirus or COVID-19, we only have 2 weapons, and so we need to use them well. And these weapons are social distancing and our infection control measures. All right, so just a reminder to always work within your scope of training, to follow your policy, your practice policies and procedures, seek clarification if you don't understand them, and certainly in those early days and weeks with this outbreak, our policies and procedures were being adjusted fairly quickly as new information came to hand. Most of us felt like deers in the headlight, scrambling every day to address the new instructions that were coming out to us. So do make yourself very familiar with your policies and procedures and always seek clarification if you don't understand them. I'm going to ask you to do these 3 things. If you do nothing else out of tonight, please do these 3 things. Review your hand hygiene procedure. Review your process for donning and removal of PPE. We're going to have a look at both of those. But the third thing that I suggest you do if you haven't done it already is complete the Australian Government COVID-19 training module. And the link is there for you to head to that. A real quick look at how to hand wash. But do not ever underestimate the importance of hand hygiene. Good hand hygiene can be the final barrier between you and the virus. I'll have a quick look at soap and water versus alcohol-based hand rub, or hand sanitizer as we call it, what to use and when. Both of them will work if used correctly. And which soap to use? You can use any soap. It's quite overwhelming when you're in a supermarket or perhaps choosing from your medical supply company. Any soap works. It doesn't matter. Just use soap. You might remember from your workshops that we indicated that hand sanitizer or hand rub can be more effective against bacteria and viruses on your hands. But in this particular instance, with COVID-19, the recommendation is that we use soap and water. And I'm going to tell you why. Now, if you're a germaphobe like me, you're going to find this fascinating. If you're not, bear with me because it's actually really important. Soap molecules have 2 chemically distinct parts. A hydrophilic, which is a water-loving part, we call that the head, and a hydrophobic, which is a water-hating part, that's the tail. Now the head, the water-loving part of soap, helps the soap mix with water, while the tail can interact with other hydrophobic molecules like lipids. Okay, just remember that, and let's have a look at the coronavirus. So coronaviruses get their name from the corona that actually surrounds the virus. That's a membrane with the protein spikes that are embedded in it. Now it's those spikes which are responsible for infecting the host, and they are anchored into the membrane. The membrane is a shell, and that membrane is the virus's weak point. Okay, lucky for us, that membrane is made up of lipid molecules, and they're held together by very weak chemical interactions between each individual lipid molecule. Now, scientists think that the soap's tail, remember the water-hating part, can disrupt the weak interactions between lipid molecules in the membrane and actually tear it apart. So if the virus is broken up before it has safely sheltered in a host, it won't be able to do its infectious job. The water-loving part of the soap then washes all these fragments off your hands, and hence you have actually washed the coronavirus down the drain. The other thing is that the lipid on the coronavirus membrane really loves the oils on your hand, so it's really important that we use the soap to wash those the oils and those membranes off your hands. Water alone actually won't do it. So the soap is working in two different ways. Remember that the mechanical action of 20 seconds is really important and always preferable to dry with paper towel, and that paper towel can be used to turn off the taps. Okay, if you have no soap on hand, the World Health Organization and the Australian Government of Health both recommend that alcohol-based hand rub and sanitisers will remove the novel coronavirus. It works in a different way though. Your hand sanitiser must contain alcohol or a mixture of alcohols, and it must be around about 60%. They're thought to work by preventing the protein, and we said that the infectious part is in the protein that's embedded into like little sticks, and we've all seen those coronaviruses floating around on the news. So the protein are those little sticks, and that's the part that does the infecting. The alcohol actually prevents that from functioning normally. But it must be, as I said, it must be 60%, and you need to check the expiry date, because alcohol can evaporate even when it's in a sealed container. And remember again that you must use the same mechanical action, scrubbing action, as you do with soap and water for the alcohol sanitizer to work. Now I'm just going to take a breath there and ask Alison if we have any questions on any of that.
Yep. So Kathy, the first question is, if you test negative but still have symptoms, should you have another test? And is it possible that the test will be positive?
Yes, is the short answer. We actually have seen that happen. So the recommendation is that you remain away from work while ever you have any symptoms.
And the next one is, should we be still taking temperatures? And is this a reliable indicator of the virus?
Should we still be taking temperatures on our patients as they arrive at the practice? Is that, yep, okay, we'll assume that that's where that question is going. Look, I'm not going to say you have to, but it's one method of, and we're going to have a look at triaging patients on arrival at the practice a little bit later. There are many reasons why people have a temperature, and one of them is COVID-19. You can also have COVID-19 and not have a temperature. So yes, it probably is good practice to do so, because if the person is afebrile, does that mean they don't have COVID-19? Certainly not. It's just one thing that you could do as part of your triaging activity. And I think that each practice needs to sit down and discuss whether that's a practical thing for that practice to be doing. But we will actually have a look at that a little bit later on in the presentation.
Okay.
Anything else?
One more question?
Yeah, sure.
Any plans for rescheduling the conference? And we are doing that the 19th and 20th of March next year.
Good news. Almost the same dates.
Yes.
Perfect. And it's the same location?
Yes,
here in
at
Newcastle.
Noah's on the beach.
Yep, on the beach. So we do all look forward to that.
One more?
Yeah, sure.
Actually, a couple more. So are the pump style hand washers as effective as soap?
Any soap is fine. So if it doesn't, soap in a pump is better than a bar of soap, because we know we get that slimy film on the bar of soap, and that actually harbours bacteria. Alison's screwing up her face for those of you that can't see Alison on camera. So pump soaps are better, and any soap is fine.
Okay. And what time frame would you allow between the negative test and a second test?
Oh, well, that's up to your clinician, because that would depend very much on how your symptoms develop or don't develop. Yeah.
Okay. And that's it for the moment.
Great. Okay, so let's have a look at the other thing that I seriously asked you to revise, and that was your PPE. And my goodness, haven't we had some challenges here with PPE? But the good news is that the national stockpile is now quite healthy, and I know that your PHN and other PHNs have been working very hard to get that out to you. Updated guidelines for the use of PPE were released on Monday, and they're available on the department website. Okay, so review your practice policy on when to use PPE and what to use. And I said those guidelines that were released on Monday by the department are your best roadmap for what to use and when and who needs it. But always when you are putting it on or taking it off, follow the protocol that's on this slide. Now, Alison, I should have asked, we are sending the slides out to the delegates? Yes, so you will get the slides. Always follow the protocol listed there of how to put it on and how to take it off. Know when your masks need changing. They all differ, they do differ depending on the quality and the grade of the mask, and I know that for some weeks there when we weren't able to get as much as we hoped, some of what was available was perhaps of a lesser quality than what we'd normally be used to in our practices. So you need to know when those masks need changing. But generally speaking, a surgical mask, can I hold this one up that's down here? It's a well-supplied PHN. The surgical masks become saturated after about 30 minutes, and that's if you haven't touched them, okay? If you actually touch it with your hands or gloved hands, you will destroy the integrity of that mask, and it will need to be changed sooner than that 30 minutes. But as I said, do check which one you have. Always remove your mask by the loops, and remember to remove your gloves with a no-touch technique, which we all practiced at length in the classroom over the course of your studies. So as I said, a couple of do nots. Do not touch your mask when you are wearing it, and do not touch your face with gloved hands. Don't fall into the trap, and we're seeing people in supermarkets and food, because they've got gloves on, they think they can touch everything. The glove doesn't do anything except provide a barrier. So the virus will live on the glove just as happily as it will live on your hand. So do not touch your face when you are wearing your gloves. All right, so we're going to have a quick look at the hierarchy of controls, which actually demonstrates, I guess, when we're doing a risk assessment, and hopefully you'll remember from your studies, and we look at this hierarchy of controls, how we actually can manage the risk of this virus. And of course, the first one there is elimination. Well, at the moment, we cannot eliminate the virus. They're working on it round the clock. Hopefully a vaccine will be available within the next 12 months. We cannot substitute this risk. We can't take the virus away and substitute it with something less harmful. So we're down to the bottom three that we have to work with to manage this risk, with the bottom one there being PPE. Now, that's not to say that PPE isn't good. It's imperative that we use it when we have to use it. But I think that this demonstrates the risk that is actually out there for us and why it's so important. Alison, before I move on to environmental cleaning, have we got any more questions?
Just one more.
Sure.
Should the AHR be 80% for medical practice as per the TGA?
No. So the guidelines from the health department are that it needs to be 60% or more. It can be a mixture of different alcohols. It doesn't have to all be the same. But that's what they've said at the moment, 60% or more. I mean, the more you've got, the better, but 60% is the minimum. All right, so we're going to have a look at environmental cleaning, and we're going to have a look at before COVID and after COVID, just so we can demonstrate the difference in our workflows, in our practices, and where the MPA role may be utilised effectively in environmental cleaning, which is a really important part of our infection control processes. So if we have a quick look at our reception area, we would have cleaned our desk, our phone, our keyboard, our mouse and our pens, maybe once, maybe twice a day, hopefully twice a day. Now we have to clean that area every time you leave your station and somebody else comes to it, every time you take a break, every time someone uses the pin on the FPOS terminal, puts their pin into the FPOS terminal, every time someone picks up a pen. These things need to be cleaned. In our waiting rooms, we may have cleaned, well, hopefully we clean our waiting rooms daily, maybe twice daily. Some of the things in the waiting room may have been cleaned only weekly, as per our RACGP standards. Now we have to clean it more frequently throughout the day, and that depends very much on your patient flow. And when we have a look at scheduling, you know, there are things that we can do to help us with this cleaning and this workflow, but especially doorknobs, the arms of the chairs. We have to take away magazines, books and toys. You might think about your check-in kiosk if you have one in your practice. Is it something that shouldn't be used? Because if it is being used, it needs to be cleaned between each patient, and that can be very taxing. So whilst it's a method of keeping distancing, keeping our patients away perhaps from the front desk, we need to weigh up that risk and see what you can do in your practice to manage that risk. And we've seen a lot of practices install perspex screens and other barriers. So just remember, they actually need cleaning as well if you do install them. Let's have a look at our treatment room. Well, if we operate on the premise that all patients are a potential source of infection, then our processes in our treatment rooms will actually not change all that much. We'll still be cleaning between every patient and every procedure, every piece of medical equipment that's used. I think one area of our practice where we've probably had to ramp up our processes is the consult room, which we may have cleaned twice daily, twice daily, depending on your patient numbers. Those consult rooms should now be cleaned between every patient. So the bed, the arms of the chairs, the doorknob, any equipment that gets used, removing magazines from the consult rooms, and thinking about cleaning those down between clinicians, because sometimes those rooms are used by different clinicians, so they've got to be cleaned out. So that has really increased our workflow. So what do we clean with when I talk about environmental cleaning? And just like C comes before D in the alphabet, you have to clean before you can disinfect. So some organic matter that may be on surfaces will actually inactivate the disinfectant. Unless you've removed that soil load from a surface first, the disinfectant may not be able to do its job. In order to clean coronavirus from these surfaces, we need to do both. It is all right to use a combined wipe. So your wipes must contain a detergent and a disinfectant if you are going to use wipes. And the disinfectant needs to be either hospital grade or what we call virucidal. You may, if you have had positive COVID-19 patients in your practice, and you may not know, but it may be after the fact that you find out, you would then need to do a terminal, or what we call a terminal clean or an infectious clean. And the link there provided to you in the slides will actually take you through to the Department of Health document on how to do that, and also other recommendations for cleaning your practice. And how do we clean? I just want to remind the MPAs about the one-way technique, okay? Always remember to use your one-way technique and never go back over a clean area with your dirty cloth. That was something else that we did to death in the classroom. So just a reminder about that. Wear gloves when you are cleaning, and then perform hand hygiene. And again, being careful not to touch your face until that hand hygiene has been performed. So our workflows have increased exponentially, and there's a very big role for the MPA to play in ensuring our practices are as safe as possible and minimising cross-contamination. They've got an MPA's very strong fundamentals in infection control that underpins many of the units that you do through your course. So think back to those fundamentals, and now is the time to absolutely employ them like you never have before. Any questions on cleaning, Alison, before we move on?
No more questions, Kathy, but I just wanted to say if anyone can hear some background noise, it is pouring here in Newcastle, so that's what the sound is.
All right, I can raise my voice. If people can't hear, just let us know and Alison will tell me to shout. Apparently I've got a 5-acre voice and it's carrying very well, so we're all good. All right, so what other areas can the MPA be utilised effectively in while we manage COVID-19 in our practices and beyond? Just a quick reminder about clinical governance. And clinical competence must be signed off. You must have the certificate awarded for that skill before you actually perform it in the practice, and that you are always working under the supervision of a nurse or a doctor, that there is insurance and policies and procedures in your practice to cover the tasks that you are performing, and that the clinical governance always sits with the doctor or the nurse. All right, let's have a look at triage and appointment management. All right, so in triaging our patients before they come into the practice, the questions that we're now asking are going to be with us for some time. And we are asking questions like, have you travelled overseas? Have you travelled interstate? Do you have any cold and flu symptoms? Have you had any contact with anyone that has known COVID-19? And are the other members of your household unwell? So there's a big role for an MPA in triaging patients over the phone and gathering that information that then decides what type of appointment that patient may need, whether that patient does need to come into the practice, whether that patient is suitable for telehealth, perhaps whether that patient needs to attend one of the respiratory clinics or the COVID-19 testing clinic. So gathering that information in order for the clinician to make that decision. Hopefully in your practices you've developed some triage checklist and policies as to what type of appointment is suitable for telehealth, and Alison told me earlier that you've done quite a bit here in the Hunter Central Coast on telehealth. And we'll talk a little bit more about the MPA role in telehealth in the next few slides. But scheduling of patients. Now scheduling, we can't always use physical barriers, you know. We don't always have the room or the luxury of having respiratory patients in one room and all of our other patients in another room. So we may have to think outside the square and provide virtual barriers. Are we going to see all our patients that have respiratory infections at the end of the day? And I was saying earlier that can help with your cleaning, because you're going to schedule all those cold and flu symptoms towards the end of the day. You can do a great big clean when the day is over and you know that you're ready to go again the next morning. Or are you going to ask patients to wait in their car until they come in? Like the supermarkets, are you going to see all your elderly patients first thing in the morning, perhaps to isolate them from any other risks? Every practice will be different, and that will depend on the physicality of the practice and the demographic of the patients that you are seeing. But I guess we have a focus on scheduling greater than we have had in the past to make sure that we're protecting the vulnerable and keeping the flow of patients through the practice, because that 4 square metres applies in our practices just as it does anywhere else. And we have to make sure that our waiting rooms don't overload, that we can maintain that social distancing in our waiting rooms as well. So patient flow is important, keeping your eye on the waiting room and having some really good scheduling. And as you would remember from your course and the unit that you do on appointment making and scheduling, there's some skills there that you will need to exercise. Triaging at the practice. So on arrival at the practice, are we taking the temperature of the patients? Well, in my practice, we certainly don't take the temperature of every patient that arrives, but we do take the temperature of anyone that has got any symptoms. So you're going to have a look at your practice and see what is best. I mean, if you have scheduled in groups and you've got all your unwell people at the end of the day, then you will probably be taking the temperature on all those patients that arrive for that session. I can't tell you the right or wrong thing to do. You've got to figure that out in your own practices. Now, the other thing that the Chief Medical Advisor said this morning is that they are expecting outbreaks. So your policies and procedures may change, if you have an outbreak as to when there isn't an outbreak in your community. You may have to ramp up some of your practices if there's a suspected outbreak in your community. So you've just got to be constantly reassessing that risk as we move through this time. Okie dokie. Any questions, Alison?
Yes, Kathy. Any thoughts about alcohol-free hand sanitizer, which claims to kill 99% bacteria? Is it any good?
Okay, so I really think that the best thing to do is to go back to what the health department, the guidelines that we're being given, and if you remember in my earlier explanation, it's the alcohol that they think is breaking down the protein. So I would be very cautious about using a hand sanitizer that doesn't contain at least 60% alcohol. I know there are a few around, and there's certainly a brand around that someone was showing me that actually claims to spike the virus, to actually break the protein. I don't know, but I'm going to follow the department's guidelines and use hand sanitizer with alcohol, because they think it's the alcohol that's working. So I would stick with alcohol.
That's all.
Okay, good. Although, can I just remind you all, those of you that have been in a classroom with me, you're only allowed to ask questions that I know the answer to. That's the rule. That applies. Okay, so I think, where are we up to? All right, so a quick look at telehealth. We've talked a little bit about the scheduling of telehealth and it not interrupting the flow of the patients that are face-to-face in your practice, because you cannot have your waiting rooms building up to the capacity that you can't manage. So thinking about where the telehealth is scheduled during the day. Probably doing it in blocks rather than random. Documentation with telehealth, and I've got that there because one of the things that we know post September 30, when Services Australia, Medicare do catch their breath and start to have a look at the practices that we've employed around telehealth, is that they'll be looking to see that we have documented the verbal consent of the patient to send the billing to Medicare. So ordinarily, as you know, they sign a form, or they press the Tyro terminal, they press to send to Medicare, and that's deemed consent. At the moment, the department is saying that they will accept verbal consent, but it does need to be documented in the patient's file. So I can see that when as MPAs, when we're making those appointments and explaining to the patient, how the telehealth works, that would be a very good part of that conversation and should actually then be immediately documented in the patient file. That will save the clinician doing it, and it will ensure that when the auditors come, that you've at least got that part covered. If you are not bulk billing your telehealth, if you are private billing telehealth now, which is quite okay if it's not a vulnerable patient, we would need to see that there was informed financial consent, and that's something else that we talked a lot about during your training. So remembering that would also need to be documented in the patient's file, that the billing had been explained, that the patient understood how payment was going to happen and how much the consult was going to cost them before they went ahead with it. Telehealth does pose some problems to privacy, and we need to think about those, especially with a video consult, knowing who's in the room with the patient at the other end when that video consult takes place. As an MP, if your system in your practice is for the MPA or the reception admin people to phone the patient to get them on the line for the doctor, how do you know that you've actually got the right patient? So remembering that at every encounter, we still need to identify our patients using 3 different identifiers. So when you make the appointment, when that first contact happens, and then again when the clinician comes in on the consult. So that identification process still needs to be maintained. And I wonder if you're phoning a patient for their telehealth because it's time for their consult, but they don't answer the phone. What is your conversation then around how do you get that person to the phone for their consult? Because their family member that answered the phone may not actually know that they have a doctor's consult. So you need to sit down in your practice and think about all these things and think about how you're going to actually manage them. I also think it's really important to educate the patient on what the expectations of the practice are around telehealth, and MPAs are well placed to do that. How many times are you actually going to contact the patient before you give up because they didn't answer the first time, and what are your processes around that, and what are the risks for the practice? How are you going to follow up that the patient didn't answer the phone because they actually had a heart attack and were on the floor rather than they just missed the call? So thinking about those sorts of things and letting the patients know what your expectations are as well. And having all this documented in the patient's notes are really important. At the end of the consult, your role may be to take payment, and that poses even more importance to the process because we actually are taking financial information. If you're taking credit card information over the phone, what do you do with that financial information when you've when you're finished with it? What do you tell the patient that you're going to do with that financial information? I mean, obviously you're not going to store it, but they need to know what happens after they've given you their credit card details, and then processing that consult off to Medicare as well. At the end of the consult. You may be doing it before the consult, or you may be doing it at the end of the consult. The other thing that you need to think about with regards to patients' expectations is what's going to happen post September 30 when the rebated telehealth probably will go away. We've got it to use until September 30, and after that we're not quite sure. So some really good messaging to patients that this is only in place for that finite period of time. It's going to be very hard to take it away from them at the end of that. So I think those conversations when you're making the appointment, those opportunistic conversations to educate your patient around that, around how telehealth actually works. MPAs are also really well placed for patient education around their health. And that little picture has jumped up on top of the words there. That's okay. Teaching your patients about hand hygiene, why soap and water is better, what to use when, getting them to hand hygiene at arrival at your practice is really good. Getting them, don't get them to touch their face. Teach them about not touching their face. Teach them about not touching surfaces that they don't necessarily have to touch in your practice, like the reception counter, the front counter. Teach them about social distancing and lead by example there. You need to social distance at the reception desk as well. And what it says under that little piggy who stayed home is teach your patients to stay home wherever possible. And again, we are told not to be complacent. We're actually not quite sure what the next few weeks will bring. Educating your patients around the flu vax. I think we've probably just about vaccinated our entire patient population, and MPAs have a big role to play in that. They are well trained with managing the cold chain for vaccines. So their role in flu vaccinations is also there. A quick word again about privacy, not just when you're managing telehealth, but privacy for any of your patients that may have or think they have coronavirus or COVID-19, or even present with symptoms. Remembering that the privacy laws still apply despite the app and despite everything else that we're doing to manage this. You do need to remember the privacy of your patients and that confidential information that you hold as an MPA, as a healthcare worker. Even patient inquiries, their neighbours will want to know, were they positive? The privacy laws around that for you still apply. That's up to the public health unit to carry out that information, not us. Questions?
We use Health Direct,
Yep.
where the patient calls into our virtual waiting room. We are located in Victoria. No problems with video. Patients love it.
Awesome. If
And-
you have actually got some telehealth modalities in place, and there are a lot of them on the market very quickly, they take care of a lot of these things for you, but to remember the fundamentals still apply underneath.
Yeah. And individual staff are given a choice as to the PPE they wear when attending to a patient in the treatment room or having a procedure. What do you recommend?
I recommend that you follow the guidelines that were released on the 11th of May as a minimum. So download those guidelines. They came out before these slides were done, but we could send the link for the guidelines that were released. That's the minimum, so that's the baseline. So anything up from there is up to you. Really, if you have enough supplies and everyone feels more comfortable, I think managing patient education, but also managing agitation and anxiety is really important. Our patients, we've seen in the last few weeks, certainly in the early weeks, some very unusual behaviours in our patients who normally wouldn't behave like that due to high levels of anxiety and agitation. So if you're using them for people to feel safe, that's okay if you have the supplies. The government are asking us not to use the national stockpile for that though. So if you want to use PPE, then you need to purchase it in when and if you can. But in terms of the national stockpile, which is what's being supplied by the PHNs, to stick to those guidelines.
And with regards to obtaining consent for billing to be sent through to Medicare, does it need to be documented at every consult or once only within the patient file?
Every consult. Every time you send something to Medicare, you need to obtain the patient's consent to do so.
Okay, that's
Every consult. All right. That's about it from me. Just to remind you guys to remember what you have learnt during your MPA course. For those of you that are considering becoming an MPA, I think we've demonstrated pretty thoroughly the role that you can play, not just now, but there will be a flip side to COVID-19. We will come out the other side. Our practices probably will be very different to what they were for some time. But the role of the MPA is a very rich one in a practice, and that can be utilised very effectively in all areas of the practice. So work within your scope, know your practice policies and procedures, and stay safe.
And just a quick guest appearance from me once again, just to remind you, can you go to Slido with the code MPA and make sure you do your evaluations, because we really find that helpful and really helps us when we're trying to organise future events. So we'd really appreciate your assistance in completing your evaluation. And again, thanks very much for viewing this evening, and please keep safe. Thank you.